I'm Ross Naylor. I'm one of the clinical systems trainers from NECS. Most of you have probably met me or spoken to me before. And today we're going to have a look at SystmOne protocols. The session is being recorded, as you've probably just seen a pop-up on your screen. So microphone's on mute if that's okay, just saves me getting any feedback while I'm talking. I'd say cameras off, not because I don't want to see you all, more that it just eats some of our bandwidth. And it just might make things stutter and slow down a bit. And obviously we don't want that when we're trying to learn something fairly complicated. In regards to questions, if you don't mind, stick them in the chat for me. It just helps me keep my train of thought a little better. If I'm in the middle of explaining something, I can kind of come back around to answer the question. If there's anything desperately urgent, by all means, sort of flag that and one of us will pick it up. But otherwise, if it looks like I'm ignoring your question, I'm just waiting until I get to a point in the train of thought that I can step off and deal with it. So as I say, today we're going to have a look at SystmOne protocols. Now this session, probably more than most of the others that we've done with the GP task force, is going to be a bit of an overview and a bit of an idea of what these this piece of functionality can do. What I'm not really going to try and do today is turn anybody into an expert on protocols, because we've only got about 90 minutes. I could quite happily talk at you for a day on the things that you can do with protocols, and then we still have time to play with them afterwards. What that does mean, however, is that if we go over anything today and you think actually that looks fantastic, I'd really quite like to be able to run with that, or I'd like to be able to do something a bit cleverer with that, then give us a call via the help desk. We can do some one-to-one stuff. There is a more in-depth protocol session than the one we're going to do today that we offer. It takes about 3 hours, which we can obviously do one-to-one or one to groups, but we can also look at examples that you have, you know, to try and help you put something together. So don't expect to come away from today as a consummate expert in designing protocols. What we're going to look at today is basically the building blocks of them and the kinds of things that you can get them to do, and hopefully spot off a couple of ideas you can take back to practice and hopefully make life a little bit easier. So explicitly, what are we going to talk about? We're going to have a look at the layout of the protocol screen in SystmOne, i.e. what's on there, what can we do. We'll have a look at creating, amending, publishing and deleting a protocol, so it's managing them. We're going to talk through in protocol something called branches and outputs. So we'll look at those in a fair bit of detail. They are the way you design a protocol. We'll talk about triggers. So the option to either have people manually launch a protocol versus the option to Faust a protocol onto people if they do something. We'll look at limiting protocols to launching only for specific staff or in particular circumstances. And we'll also look at applying some filters to protocols. So basically stopping them coming up on every patient at your practice. As I say, as we go along, any questions, anything you want to ask, stick it in the chat. We'll go over it at a fairly high level, should take us between an hour and 90 minutes, and then we'll have some time at the end, so we can either talk about what a particular section does. We could even, if you've got examples, as long as they're not hideously complex, will take half a day to build. We could even have a look at building one of those in our demo unit. If you'd expect, I've got a couple of examples that I just want to play through with you, just to give you a couple of ideas of the way you might use these. So as I say, any flashes of inspiration, let me know. You'll be pleased to know that's the end of the Death by PowerPoint. We'll move over to SystmOne now. We'll actually do the rest of it in the clinical system. Because it'd be really cool to try and teach you protocols from a PowerPoint. So, for those that have used protocols before, especially in the dim and distant past, if you've gone looking for them recently, you'll notice they've moved. I say recently, we're talking about 2 years here. They used to be in setup and data entry. They've now moved to this workflow support option. Same list, still in setup, but they've just moved. So if you've gone looking for them and haven't been able to find them, that's where they are now. Fairly busy. It's a demo unit, so as you can imagine, we've got people playing with all kinds of things on here. What do we have actually on the screen? Well, up here at the top, we've got the usual toolbar, new protocol. You can probably work out what that does. View details. basically tells us the spec of the protocol and lets us see the version control. Amend protocol lets us make changes to an existing. Publish protocol, you'll have to do that when you first create one. For those of you that do the template session, very similar principle. If you build it, you've then got to publish it, or no one else will be able to see it. You can also use publish protocol to publish it wider than just your practice. I'll touch on that very briefly. We'll mention the word organisation groups, but I'm not going to go into that in horrible detail today, just because we haven't got time. We can copy a protocol. Does exactly what you'd expect it to do. Allows you to create 2 versions with small changes between the 2 or more. Delete protocol. Usual proviso with SystmOne. If you delete it, it's kind of gone forever. So use with caution. I'm a big fan of creating an archive category and sticking them in there for a while before I delete them. I'll mention that a little bit later. Import and export, like with reports, templates, etc. If you build one, and it's really quite clever, you can export it, create a file, and you can send it by email or, you know, on a memory stick, as long as your memory stick's an appropriate one. You can give it to someone else and they can import it into their SystmOne. We've mentioned this proviso before. It applies with protocols as well. If it references other things from your clinical system, for example, views, templates, letter templates, things like that, then you will also have to export and import those onto the receiving system. Sorry, Alexa, stop. Don't know what I said there to trigger Alexa, but that was annoying. I should take my train of thought away. Yeah, import and export if you need to share your protocols with other people. Upload protocol lets you put it on the resource library for SystmOne. That will make it available to all of the SystmOne units. Very, you know, utopian, very kind of you, but just be aware that it will mean other people can download it. Does mean that downloading it, they take on, you know, the burden of assuring it, but it just means that something that you've built will be visible to other people. And refresh does what it does everywhere else. It just refreshes the screen. You know, if you've just built a protocol and it's not showing up yet. Below that, we've got the list of all the protocols at our organisation, usual setup left-hand side, category, so also known as folders, groups, whatever you want to call them. Just makes things a little bit easier. Like I say, if I'm getting rid of protocols, if I'm hiding them, but I'm not quite certain that we want them gone forever, I tend to create a category called archive. Quite often call it Z archive, just so it sits at the bottom, and I'll move them to there, which we'll have a look at in a second when I'm done with them. I will also, if I'm doing that, make the protocol inactive by unticking this column in the middle. Protocol's inactive, so if I untick that one, nobody's going to see that pop up on patient records, even if the trigger would make it. Similarly, no one will be able to launch it manually. While we're talking about the section in the middle, so we've got the name of the protocol, that's just what users will see. That's what you'll see when you come in to amend it. Excuse me. We've got the icon that it's associated with. So if you have it on a toolbar or something like that, you'll see that icon. We have the category, so the folder that the protocol sits in, whether it's active or not on our unit, and whether it's available just at our unit, organisation specific, system-wide, so across the whole of TPP, one that they've built, or via a particular organisation group. So for those of you that have gone looking, you'll probably have some protocols on your systems that say Derbyshire Pathfinder that have been published through that group. And finally, the description. So there's an opportunity when you create a protocol to put a description on it. That's where it'll show. So if you need to give a little bit more detail than the name of the protocol gives, then that's where you do it. So we found where we build them. What is a protocol? Protocol, the best way I can describe it to you is kind of an interactive template or an interactive data entry or alert tool. Basically, you'll hear them called macros or matrix or that kind of thing. It's a decision-making tool. Some of it can be automated, some of it can't. Some of it you'll want automated, some of it you won't. But basically, they allow us to take a user down a particular path, show them particular updates or alerts, or get them to fill in particular things based on the path that they've either chosen or the patient record has taken them down. We're going to look at some of the ways that you can guide those paths. And to do that, we're going to hop straight in to creating a new protocol. So over here, top of the left-hand side. Okay, so page one, very similar to everything else, template is SL. We've got a name. So for this one, we're going to call it housebound patient. If you can spell patient, which you'd think 11, 12 years in the NHS would have taught me to do. Category, these are those folders. If I wanted to create a new one, a bit redundant because we're creating it new, but if I wanted to create my archive category, new category to the right hand side, I could put it in there. I need to change it. I can either pick from the list, or if the option I want doesn't exist, I can create it as a new category. I'll put it in there so I remember to get rid of it afterwards. Ditto subcategories. Basically, if you just need to break that up further, so you might have medicines and then you might have prescribing alerts, stopping alerts, changing alerts, however you want to work it. The icon, this is the bit that takes the longest part of the process, as you can imagine. And you've got so many to pick from and people tend to agonize over it. Now I'm just going to pick the little house, the housebound patients. And the description, as I say, if the protocol name doesn't give us enough info, we can put a little bit more in there. That'll at least give someone an idea of what it's intended to do. Then we come to the trigger. Protocols fall into two very distinct categories: manual protocols and automatically triggered protocols. A manual protocol, as the name suggests, relies on a user clicking it, and it's generally used to help them make a decision that they know they have to make. So, for example, I'll pick on one that we've done earlier. On the Derbyshire Pathfinder, there's a manual protocol. You have to click a button that says 2-week wait form, and that will take you through a couple of steps, and then it will say to you, which hospital do you want to refer to? Do you want to send them to Derby, Nottingham, Leicester, Kingsmill, etc.? So a manual protocol, one that's triggered manually, is one that a user clicks on and then it starts the protocol. There's no automatic launching. Conversely, we can have an automatically launched protocol. And in our example here, we need this protocol to launch automatically because we want it to tell us if the patient's housebound. We don't want someone to have to think, I need to know if the patient's housebound, and click on a button. So we need a trigger, something that tells SystmOne to launch that protocol automatically. And we've got a defined list of triggers here. Now, this is one of the bits that takes some explaining, so bear with me. The trigger is fairly broad. The trigger is the action that makes SystmOne look at the protocol and decide whether or not it needs to launch it. Important point there is that there's still a decision afterwards. Yes, this is what makes SystmOne look at the protocol, but we can also tell it to decide whether or not to launch it on the next screen. So the trigger is going to be fairly broad. And in this example, we want this to trigger when someone retrieves a record. So every time someone opens a patient record, we want it to look at them and say, is the patient housebound? And if they are, we want it to tell the user. So we're going to do this on patient record retrieval. See, there's some of the options. Time allowing today, we'll go through a few of these. They're fairly clearly defined. So it'll be things like, you prescribe a particular drug, you prescribe a drug from an action group. If you give antibiotics, it might prompt you to go through some sick day rules, that kind of thing. Now that's fairly broad. We can narrow that down slightly. First option, prompt to launch when multiple protocols apply. That basically, you'll have seen this before, I'm sure, especially if you've done any GP to GP summarising, because you'll find normally that because you're entering a lot of information in one go, you'll probably trip a couple of protocols, things like the sepsis one, if you pull through a temperature over a certain amount, or the screening ones, that kind of thing. What that basically says, if the protocol is triggered at the same time as another protocol, these get a pop-up and they'll be allowed to choose which protocols will run. If we don't want to give them the option, if we just want it to launch no matter what, we untick that box. Restrict triggering to specific staff roles or staff members, really quite a useful box, and this is a particular one. So if we've got, say we had a protocol to prompt our admin staff to check patient phone numbers when they open a record, when they make contact with a patient. We all know that that's really going to annoy our GPs if every time they open a patient record, they get a pop-up to say, make sure you check the patient's phone number, and it takes them off into the patient's details. They'll tell us that they've got other things to do in that 10 minutes, and to be fair, they have. So in that case, we might want to restrict our protocol to only triggering for specific roles. And hopefully you'll be able to see here, this little column that's sort of in grey, that will show us a tick if that role exists on our unit. And all we do is double click on the ones that we actually want it to apply to, and we build up a list here. So we can say, okay, SystmOne will trigger this for receptionist access role, but it won't trigger for clinical practitioner access role, or maybe vice versa. Maybe we've got a clinical protocol that we don't want to trigger for and confuse our receptionists. So we can tell SystmOne not to show something for certain people if it doesn't apply to them. Similarly, we can do that by staff. I'm a big fan of restricting protocols to me while I'm testing them. So if I restrict that just to Ross Naylor, basically what that means, if I'm building a protocol and I want to see if it works on live patient records, then I can restrict the protocol to me, and I'm the only one that will see it. So I can use it in the wild without the fear that something I've put on there being wrong and it throwing one of my GPs off or one of my receptionists off. Just remember, if you do that, once you're happy with the protocol and want to make it live, to come back into the screen and just remove the restriction to yourself. Restrict triggering specific unit types. You're unlikely to use because I think everyone on here is going to be in a SystmOne GP unit. But if you're publishing this across a wider area, you might say, for example, that this protocol applies in GP units but doesn't apply in minor injuries units, that kind of thing. So the trigger is the action in SystmOne that makes it look at the protocol and decide whether or not to launch it. And then the trigger can be restricted to certain people or certain roles. Now, as I said, that trigger is going to be fairly broad. It's things like opening a record. Any user opens a record, it triggers the protocol. Or any user prescribes a medication, it triggers the protocol. What we can then do is filter the triggering of our protocol. So, protocol triggers on a record being opened. We can then put a condition into the protocol that says, okay, check when I open a patient record, but only actually go through with the protocol in certain conditions. First couple are fairly obvious, gender and age. So if we had a protocol to look for patients that hadn't responded to a smear invitation, for example, it would make sense to only trigger that on female patients above 25, I think it is. Don't quote me on that. I've not been with smears for a long time. Similarly, we can trigger a protocol based on a patient's inclusion in a report, so a clinical report. This is the one we're going to use now. I'm going to click the little report icon. Excuse me. I'm going to sneeze. And we can search for reports. So I'm just going to search up here, up to housebound. Varying degrees of. I'm not going to make you watch me build a report as well. You'll have probably seen me do that. I'm just going to pick on that current housebound patient. So now my protocol is only going to trigger when a patient record's opened for me, if the patient appears on the clinical report, current housebound patients, little blue eye, lets me see the spec of the report. Joe's built it, trust Joe, so we'll go with that one. The other things you can use to filter patients in a group. Now, if we've got time at the end, I'll whiz through this one fairly quickly. It'll be a very similar idea, but a group, for those of you that haven't met it, is an ad hoc patient group in SystmOne. A list of patients that works very similarly to a clinical report, except for the fact that rather than finding the patients automatically, you have to put them into the group. Things like, I don't know, those naughty patients that you want the pop-up to appear on to sort of handle with kid gloves. There's nothing on their record, there's not likely to be anything on their record clinically that will link them all together. So you couldn't find them with a clinical report, but you could put them in a group of patients that need an extra bit of cajoling when they come to the desk. Finally, we've got QOF registers. I'm sure you've all seen enough of those, given that it's coming up towards March. We can restrict it to any patients on particular registers if we need to or want to. So that's the filter. That'll apply after the protocol triggers. The trigger basically makes SystmOne look at the protocol, decide whether or not to launch it. The filter then decides whether or not it applies to that patient. Finally, we come to the design page. This is where we have the most fun. He says, I'm doing air quotes, but you probably can't see me there. So, the design page. What we're going to do, we're going to play down these fairly steadily, but we're just going to look at what each of the fields will do. Any questions, as I say, stick them in the chat. We can always come back to one of these nodes if what I say is fairly unclear. I'm just going to play my way down, and we're not going to build it yet. We'll look at what they do, and then we'll rewind and actually put together this fairly quick protocol and explain what it's going to do and why it's going to do it. So, protocol steps, the design steps, come in two flavors. Branches are basically a decision. Automated or manual, branches are basically where the protocol will fork off down different routes. Outputs are the thing that happens when you go down a particular branch, and they generally fall into two categories: adding information to a patient record or presenting information to the user. Variables, this bit you can see down at the bottom, I am not going to touch today. Nor am I going to touch subroutines. If you are interested in those, give us a call through the help desk. They definitely repay a one-to-one session. They're fairly heavy, but you can do some really clever things. Variables, an example. If you want to build a scoring system, let's pick on something like, you know, ideal weight. If you want to work out, you know, patients, Cockcroft goal. Yeah, I can't even say it, let alone describe it. The Cockcroft goal formula for renal disease, I think it is. You could build a scoring system based on variables to work that out for you and give you an output. It's not something we're going to be able to cover today. We could spend half a day talking about variables just on their own. Similarly, subroutines. If you want to keep reusing a bit of a protocol, you can build it as a subroutine, and then you can just drop it into an existing protocol or a new protocol without having to build it from scratch every time. But we'll move on from those. So, branches. Decisions, basically. Some of them automated. So age, if I click on that and click into the design area, you can see there it's giving me two outputs. One is the patient greater than or equal to 16 years. Two, are they younger than 16 years? System's going to check that for me. So if my patient is 15 and a half, it's going to take me down the 0 to 16 years. Free text. Basically, we can get a protocol to make a decision if a block of free text is seen in the record. Now, you can see there, it has to either be in consultation narrative or against a read code in the record. It also has to be exact. First thing, don't get excited about this and think you can do this in report as well. You can only do this in protocols. So nothing is changed on the reporting side. You can't suddenly report on text. But it does have to be exact. I'll be perfectly honest, I don't think I've ever used this in anger. But we could do. We could get it to look at a patient record, and if it sees a little block of text, then it does or doesn't shout at the user. In report, very similar to the in report filter that we applied. Two differences. One, obviously we can stack these, we can have more than one. So we can base our protocol whether the patient is in several different reports You know, for example, if we were building a protocol for reception to tell them which blood tests a patient might need for their chronic disease review, we could build one that was based on whether or not they were in several different QOF registers by adding several different reports together. The other thing, obviously, is that can be placed anywhere in the protocol, so they can get so far in before it queries the report, whereas the filter applies as soon as the protocol's triggered. Numeric, so do they have a value above or below? So if we were doing a protocol for our INR patients, our warfarin patients, we might say, do one thing if their INR is above 2, do something different if their INR is below 2. That's all the numeric branch does. QOF code, do they have a code in the QOF cluster on their record or not? So if I pick on smoking status, it's smoking status. So if they've chosen not to give the smoking status, we do one thing. If they have given the smoking status or it's not required, we do a different thing. QOF indicator, same principle. So are they on the AF register? Yes or no? Again, all of these so far automated decisions on the behalf of the clinical system. Does it see that information on there or not? Question is where we get slightly more involved, because the question node, basically let's just type in a question. Does the patient have the thing? Because I'm not feeling very creative. Yes or no? We get to outputs. If it's not a yes or no question, we can change that. So let's pretend we're doing an IMS protocol. Which IMS are you giving? Yes or no doesn't really help anybody, but we can delete those answers and we can put our own in. So again, I've not touched the green book in a while, so don't shout at me if I get these wrong. But hopefully you can see where I'm going with this. And we can have an output for each of those. What you will notice is you'll always get a cancel as well, so you don't need to necessarily put that on yourself. Question, unlike the others, is a manual intervention. So the question box will pop up for our user and it will ask them to pick a route. Everything up to there, from A's down to QOF indicator, system's going to decide it for you, basically. Read code. Does the patient have a read code on their record? Let's go for one of my favourite examples. Do they have a diabetes code on their record? Could have done that with a QOF indicator, but I thought I'd just change it up slightly. There we go. And we're matching on child codes. If we only wanted that code and no others, just untick that, very similar to the clinical reporting. And finally, gender, again. Basically, depending on the output, it'll take us down a particular branch, and again, that's going to check the record for us. So there are our branches, there are our decisions. What route are we going to take through the protocol? The outputs are what's going to happen when the route has been chosen. So, action. Those of you that did templates or have ever built a toolbar or anything like that in SystmOne will be familiar with the concept. Actions are basically, asterisk in front of this, anything that you can do in SystmOne, with a couple of exceptions. An action could be anything from create a new letter. So if mine said patient has this, that and the other, and the output is you need to refer them to ... we could get it to launch a mail merge letter from our folders. The action might be that if you've clicked yes to a question, I want to take you into the appointment ledger so you can book the patient an appointment. You'll see there, if I double click on a node, it gives me the option to change it. It might be that if you've clicked no on something, I want to take you to prescribe. So I can go near acute. And I could even say which drug I want it to give when you go down that route. We could spend the rest of the day and then some looking at all the individual actions, but the basic principle is with exceptions. If you can do it in SystmOne, you can probably trigger it as an action in a protocol. Action return performed. Now this is a little bit more restrictive, but it doesn't look like it will be when you get to this screen. Action return performed is very similar. It will take the user to do something. The difference is using action takes them off to do it and leaves them to it. Didn't mean to rhyme that, but there you go. Action return performed checks whether or not they actually did the thing that you took them off to do. The caveat to that being that SystmOne obviously has to be able to check whether or not that thing was done. Some things it can't, and it will shout at you if it doesn't think it can. So I don't think if I take you to the appointment ledger, it's going to shout at me and say, I can't really check, because it's not saying book an appointment. It just takes them off to the ledger and lets them do what they need to do. Whereas if I say, for example, from a template, so let's pick up just out of the blue the assessment for the Wells DVT score. I can tell the protocol to pause while they do that. So it just means that it'll take a breath. It won't keep rolling through all the steps while they do that thing. As you can see there, we've got two options. So if they do the Wells DVT score template, the action return performed will take you down the yes branch. If the template triggers for them and they just close it without putting any data on it, it'll take us down the no branch. So action return performed, very similar to action, more restrictive list, but it has to be able to check that the thing that you asked them to do was then done. Quite useful for templates, because you could say, for example, pick on one that we've done recently again from the Pathfinder. We've just put a cancer safety netting template on the end of the 2-week wait forms template, and that checks that the action returns has been performed, so that something, i.e. the cancer safety netting read code, has been checked on the template. If it hasn't, so the action return performed would be no, it loops the user back around and basically says, are you sure you don't want to carry out any safety netting? Just a little way of sort of checking that they've done the thing that you expected them to do. Add code, so that will add something to the patient record, like it does with most things. So if our protocol has a question that says, does the patient want a flu jab, and the user clicks no, we could get it to put the seasonal influenza vaccination decline code on without the user having to go in and pick it. So add code is basically going to happen if the protocol hits that branch, and you'll see that a little bit later when we build a slightly more complicated one. Add note, same principle, but it's going to chuck some text on instead of a read code. So if we've got a template for, red flags and safety netting, if the GP says, yes, I've discussed all that with the patient, we could get it to put the, if no better, come back in 2 weeks, ... kind of stuff on, without them having to type it all manually. Information goes the other way. So add code and add node, put that on the patient record. Information shows us as the user something instead if the protocol branch takes us past that node. Same principle, it's just a formatted text box basically. What do we want the person to see? What do we want to tell them if they get to this point? Patient plan, some of you will use it, some of you won't. It's that little yellow box that comes up on some patient records. Some places use it more than others, but it just means that we can apply a patient plan if the patient record takes us down a particular route in the protocol. Finally, we can embed a protocol within a protocol. You can get quite inception with this kind of thing, but if we've built a protocol already and then we need to reference it from a more complicated protocol, that's how we do it basically. And finally, we can put a stop node into a protocol. Just basically tells SystmOne, if you hit that, we've hit the buffers basically. We don't need to do anything else. Okay, so on the theme of the stop node, you don't have to put those in if there is nothing else. It sometimes makes your protocol easier to follow, especially if it does get quite complex. we don't have to put stops in. It's, you know, if there's nothing for the protocol to move on to afterwards. Okay, so we're going to start with our really basic protocol. Go back to the details tab. We're looking for housebound patients, triggered automatically when the patient record is retrieved, but only by me. Filtered on the report current housebound patients. So it's only going to show if my patient is in the report currently housebound, so they've got a code on their record. And the design, what we want it to do, we want it to start, obviously, always has to start. We just want it to pop up and tell the user that the patient's currently housebound. So for that, we don't need any branches because the decision's already been made by our filter. We just want an information tab. We want something to show to our user. Usual formatting rules apply. Those of you that have ever used MS Word will know all of these buttons like the back of your hand. Maybe we just wanted to say, patient is currently housebound. Now, at the moment, nothing's going to happen because the protocol doesn't know where it needs to go. What we have to do once we've put nodes onto a protocol is join them together. So we click on the start button. Every protocol has a start, and we just drag to the next node in the chain. So what's going to happen now? When we open a patient record, so we retrieve the record, as long as it's me at the moment, then our protocol is going to have a look at the report current housebound patients. If the patient's not on that, it's not going to go on with the protocol. We're not going to hit the start bit because the filter will take them off. But if they are on that report, we're going to go through to the design, the protocol is going to start, and it's going to pop me up a box that says patient's currently housebound. So I click OK. It reminds me that I need to publish my protocol, and it takes me back to the protocols list. So for those of you that have done clinical templates, etc., you'll have seen this before, but our protocol has dropped down here at the bottom of the left-hand side into the unpublished folder. And there we go, housebound patient, my GP task force training folder. Like with most things in SystmOne, I right click on it, I publish it. It's going to make it available for use, obviously. We've restricted it to only triggering for me, so it's only going to be visible for me at the moment. I'm going to say yes. And at the moment, I'm just going to publish it locally. It's only going to appear on my SystmOne unit. Now I'm going to cheat slightly here. I'm going to use the reporting screen rather than trying to guess at patients that might have housebound codes on the record. I'm going to pick on Joe's report. Make sure it's the same one. That's it. I'm going to show patients. Right, that's me. And we're just going to hop into one of these records. All made up, obviously. Demo unit, test patients. You're not going to see anything you shouldn't do here. So we'll pick on John Brown. It'll think about it for 20 years. I meant to exaggerate when I said 20 years. I don't want it to actually take 20 years. There we go. Don't know why it's jumped SystmOne over to my other screen, so apologies for that. But the protocol has triggered. What I'm just going to do, I'm just going to move that back over so you can actually see what I was doing. And I'm just going to, oh, he's not playing nicely. Basically, hopefully you can see there by opening the patient record, because he's got a code on him, so it appears on that report, I get the information box that I set in the protocol. I click OK, the protocol closes because it has nothing else to do. What I wanted to show you, I'll go back into it. Not sure why it's taking so long today, guys. Apologies for this. What I want to show you is what will come up on the right-hand side of the screen when a protocol triggers, unless you tell it not to. Basically, it'll walk you through the protocol, the steps that it's taken. Now, if you don't need to see that going forward, you can untick the box at the bottom. Most users will do so the first time they see this pop up. But for those of us that are building protocols, it's sometimes quite useful to see how it's got to where it's got to. Okay, so that was fairly basic, hopefully. We've triggered it on the record being opened for one user at the moment, me. We've filtered it based on the fact that the patient appears on the housebound report, and we've popped up a simple information box just to tell them, just tell the user, I should say, basically they're housebound. Okay, so let's get a little bit cleverer. Let's try and do something. Let's do one that we launch manually first of all. So I'll discard my patient. We're going to go back to our setup, workflow support and protocols. And we're going to do a new protocol. And this time, let's say the example will be a little bit fudged here because we're relying on documents in our demo unit. But let's say, for example, we want to ask our user which hospital they're referring to, which form they want to launch. So, give it a name. We put it in a category. So I'm going to use the one that I just created so I can go through and clear these out afterwards. We have to pick an icon. We can give it a description if we want to. So just something that tells anyone looking at the list of protocols a little bit more about what it does. Now this time, the trigger is going to be manual because our user is going to know that they need to pick this. Maybe we want to put this on their toolbar. Maybe we want to put this on a clinical template that we've already built. So they've got to a point they want to launch a form, and we just want a little question to come up for them to say, okay, do you want the Derby form or the Nottingham form? So we're not going to set an automatic trigger. We're just going to let them launch it manually. In this case, we're not going to filter it because the user is making a decision that I do want to launch that form. At the moment, we want them to be able to use that. But actually, most of our 2-week wait forms for Derbyshire, in fact, all of them, I think, are designed for use for patients 16 or over. So we might say that even though the trigger is manual, the user is going to click on a button to launch that, we can still put a filter on that says that the minimum age is 16 years. So people can't click that button for a 14-year-old. Same design screen, so that doesn't change whether or not the protocol is manual or automatic. This time, we want the user to make a choice. So we're going to add a question when the protocol launches. Derby or Nottingham form? Yes and no doesn't help us in the slightest here. So we're going to delete those answers. We're going to add our own. Although hospital trusts are available. We're going to say, okay. Remember, we have to link our nodes together. So we go, okay, protocol launches, we ask the question. Depending on what they say, we need to take them to a different output. So each one of those, first of all, is going to be an action. It's going to be a new letter. You're going to have to imagine that these two letters say Derby 2-week wait form and Nottingham 2-week wait form, because I haven't set those up in here automatically. So imagine this one says Derby 2-week wait. We link our Derby node to that one. We might do another action, or we will do another action, I should say, to launch a letter. We'll do it with sender and recipient. Obviously, if you've done the letters course, you'll know what those are. Imagine that this one says Nottingham 2-week wait form. We want the protocol to pause while the user does the form. We don't want it to keep running in the background until they're finished. We link our node, so if they pick Nottingham, it takes them to our Nottingham 2-week wait form. Now, it may be that once they've done the form, we want to ask them, did you send the referral? It might be they've looked at the form and said, actually, the patient doesn't meet the criteria, I'm not going to proceed. So we can put another question into our protocol. Did you complete the referral? Yes or no? We link the form to that node. And we can link two to the same node. So even though the forms will be different, the next question is the same, whether it's Derby or Nottingham. Did you refer the patient? If our user says no, then we can just put a stop in. Oh, let's say proceed, it doesn't really matter. So if they say no, I didn't complete the referral, nothing happens. But if they say yes, I did complete the referral, we can get the system to put a fast track referral code on. And that'll happen automatically. So the user doesn't have to go in and pick that. We're putting the output add code. So if the protocol follows through to that point, it knows it has to add the code. The user selected a trust. They've gone through a letter. They've told us that yes, they did complete the referral. So we have the code. If they say no, I didn't complete the referral, we're going to stop. You say okay. It reminds us that we need to publish it, so we will. So we come down to the unpublished folder. We right click on ours and we say publish protocol. We'll publish locally so people can only use it on our unit. And this time, if we hop into a patient record, I'll use my old go-to. Again, any resemblance to people real or made up is completely accidental. This guy is very fake. He's got a housebound code on his record, so the one we built earlier has triggered automatically. But the one we just built doesn't trigger automatically. We didn't put a trigger on it. The trigger is manual. So how can we trigger it from within his record? A couple of ways. We could add the protocols node to the clinical tree, which I don't think I've done. And we could search for it in there. It'll work. It's fairly long-winded. It's not the way I would normally do it. We could embed it in something like a clinical template. We could have a button on that says launch the 2-week wait form protocol. But I'm not going to sit here today and make you watch me build a clinical template as well. We could add it to our toolbar. So if I amend my button set and just search for protocol, I can pick specific protocol. And I could launch it from there. Hopefully you can see the little red button now. Or I could add it to my SystmOne launcher. So for those of you that have had a play with the Pathfinder, we recommended this for that as well. I can hit F12 on my keyboard. It will open the SystmOne launcher, a bit like a speed dial, for templates, auto consultations, protocols and questionnaires, basically data entry-ish kind of stuff. And I can say, search my form, I drag it over to the letter that I want it to sit on, and I can double click on it to launch my protocol. So I pick Derby, it brings up the form that I linked to the Derby answer. I go through the letters bit, I'm sure you've all seen SystmOne letters. Again, taking its time today, apologies guys. And it's launched it on the other screen. There we go. So I'd fill my letter in, do the referral, either save it for editing if I want the secretaries to it, or save final version if I'm done. I'm going to save the final version. It's going to think about it for another 20 minutes. And then you see there, it's that second question that we linked both actions to. So whichever letter our user chose from the question, it takes us to the corresponding form, the one that we linked to it. It then launches another question, did you complete the referral? If I say yes, and hop into his journal, hopefully you can see there that it's added the code that we specified, the output, without our user having to choose it. Doesn't give them the choice, doesn't ask them, do you want to add it or not? But we could give them that option with a question. Okay, I'm just going to discard him for now. Okay, so hopefully that's explained some of the difference between the two. Automatic protocols, look for something that you do. Look at whether they should or shouldn't trigger for the user that did the thing. Then look at the filter that's applied, if one is applied, to decide whether or not it should appear for that patient. And if they pass the filter, then it will go through the design. It'll hit that start option that we saw, and it will proceed through the protocol and basically either make decisions or allow the user to make decisions, show them information or add data, depending on the output, on the options that are chosen. Okay, let's look at something a little bit cleverer. We'll do a very, very small chunk of what could be a very large protocol, believe me, because I've had to play with this before. I've actually done this before in a couple of practices, and it's a huge piece of work, but it does repay itself sometimes. I'm going to go back to setup, back to workflow support, and back to protocols. We're going to do a new protocol. And as I say, really, really brief example of something that could be done. What we're going to do here is build a little protocol to help guide our care navigation team as to prerequisites for a patient who's coming in for a chronic disease review. So we'll call this one chronic disease annual review. Put it in the same category. I want to get rid of them later. I have to pick an icon. Could agonize over that for hours. I'll trigger. So again, this one's going to be a manual one. This is one that somebody is going to choose to trigger when something prompts them to. And in this case, the prompt is going to be that the patient gets a letter from the practice to say, you're about due for an annual review, give us a ring, we'll get anything set up and then we'll book you in for the appointment. So it's not an automatic thing. Someone's going to ring the practice and say, I've had a letter from you, I need to book in for my chronic disease review. We're not going to filter it at this point because we want anybody to be able to trigger that if they need to, on any patient if there's a need to. So we're not going to filter it. It's not a hard and fast rule. Generally speaking, I tend to find that I apply filters more to a protocol that's triggered automatically, because obviously we're trying to stop the system showing it for every patient that something happens on. There are times, as we discussed earlier, where we might want to stop people accidentally triggering it on certain people, but for now we're going to leave that blank. And then we come to our design. So in this example, what we want the system to do is have a look to see if the patient is on certain chronic disease registers. And if they are, it's going to tell our user which set of blood tests they need or how long they need with the practice nurse, all that kind of thing. So we're going to base this on a couple of QOF indicators. So it's going to be a really short example of one that could be really quite massive. Let's put the indicator on. Let's put them on the diabetes register first. So let's look for everyone that's got diabetes. So our protocol launches when someone tells it to. If they're on the diabetic register, we go one way. If they're not, we go a different way. We might then say, okay, well, if they've got diabetes and Let's go COPD. They'll need longer than if they've just got diabetes. So if they've got diabetes and COPD, we go one way. If they've not got diabetes, but they have got COPD, we go a different way. We might then say, okay, if they've got diabetes, COPD, and they also need a depression review, go for the depression register. What we can do with nodes, if we want to reuse them, excuse me, if we want to reuse a node, we can select it by clicking on it, and we can use our usual right click, or we can Control C to copy, excuse me, and we can paste. And what we have here now is some fairly distinct outputs. So option 1, we trigger the protocol. It looks at our patient and says, are they on the diabetic register? Yes. Are they also on the COPD register? Yes. Are they also on the depression register? Yes. So they're going to need a fairly lengthy appointment. We could pop some information up to our member of staff. So an output that says, so if my patient is on diabetes, COPD, and depression, we get this pop-up. If they've got diabetes, COPD, but no depression, and again, we can use the new node, or we can copy and paste. So our patient has diabetes and COPD. So these blood tests, not strictly accurate, but we can have a different output. And hopefully, you can start to fill in the gaps. So in this case, they've got diabetes, yes. No COPD, but they have got depression. Excuse me. And hopefully you can see sort of where I'm going with this. Obviously timings and blood tests completely made up. That's right, click on the node. Just as a hint, by the way, if you need to select node, click on the top half. If you click on the bottom half where we've got the decisions, we get the arrow instead. If we need to delete an arrow, we click on one that already exists, so one that's already linked. We draw it off into midair, and it will give us the option to delete the existing. Which we want to do in this case. And then we can just redraw it. As long as we connect it to something, it will snap to the edge of the box. What you will find, no matter how hard you try, is you can't tell SystmOne where to join that together. It will pick a point on the box and it will join it to it. It will pick the route it takes. You can't change that, and hopefully you'll be able to see there. You can't click on the arrow to redirect it. It does get a little bit messy sometimes. There's not a very neat way to sort of highlight a join and see where it goes. So sometimes you end up drawing it into midair and then redrawing it if you need to be sure. Okay. So we'll put a couple more on. You can see there I've got 4 more outputs. I need 4 more information boxes. Doesn't have to be particularly neat, but I do find that it does sometimes repay, making things as clear as you can for yourself early on. As you can imagine with this one, it could become a bit of a beast if we did all of the actual things that we might review somebody for. So what we're doing is taking each branch. So this time we're talking about patients with no diabetes that have COPD and depression. So our patient has COPD in reception. So I'd say completely made up timings and details, but hopefully you're getting the idea. This branch, no diabetes, COPD, no depression. So our patient has COPD. And finally, no diabetes, no COPD. Depression. So a different output again. And finally, they've got no diabetes, no COPD, no depression. So we could say so if we've sent them a letter, it's not seeing any indicators on the record. We might say that we want to tell our user to task me, to ask me why they've had a letter. Or we might as well get the protocol to do that for us, so we can pick an action output, something we do in the system. We can search up at the top. So new task. We pause the protocol, give them time to do the new task. And we can say, okay. So that's our protocol. Again, we've got to publish it. So we come to our unpublish. We'll find it in the list. Right click and publish. Marie's just asked a really good question in the chat. I know we can link to book appointment with nurse, but can this then link to path to create the blood form also? Kind of, is the short answer. So let's go back into our protocol. So we know we put it in the GP Task Force training folder. We find it in the list, we right click and amend. There we go. So let's take this one, for example, where we know that the output is that they need some blood tests and they need an appointment. What we can do is say we want an action. So we can do the new electronic pathology request. And then we could have another action once they've done that to take us to the appointments ledger. Unfortunately, that's about as clever as we can go. And it's one of the ones that we do get asked quite a bit actually with things like ICE and ERS when we're talking about protocols, when we're talking about actions from SystmOne. Basically, we can get to the point that we tell SystmOne to hand the user over into the other system. So we can say at this point in the protocol, you need to go into ICE and you need to request their diabetic bloods, for example. What we can't do is pre-populate those in ICE, basically because it's a separate system. It doesn't talk to it quite that well. Similarly with the appointment ledger link, we can say at this point, we've established you need to put this patient an appointment with the practice nurse, but we can't tell it to book appointment of specific time. If I go into action, search for appointment, go to the ledger, we can do the free slot. So if we've built preset free slot searches, we can tell it to only show those to the user, but we can't say, for example, drop the patient into the next appointment matching. And we'll just have a quick look at all that. It's quite nice, we've got it in a couple. Again, I'll pick on examples from the Derbyshire Pathfinder, but we've got one on there. For certain 2-week waits, the patient has to have had a UNE test done within so many months before making the referral. I think it's 3 months for most of them. So what we have is a manual trigger. They click a button. So it's a launch manually. It looks at a clinical report to see if there's a U&E on the record from the last 3 months. If it doesn't, it gives the user a question. Do you want to request it now? Or do you want to task yourself? So again, simple question, 2 outputs where we've changed them. So for that one, it will be do request now or task. And we could say ice or task. And depending on the option the user picks, they're both actions. So one is new electronic request. One is an action of new task. But as Marie says there, it just gives the user that prompt rather than having to remember at the end of the protocol. We can take them to the thing now. Delete those for now. So hopefully you saw that. I was able to drag and highlight, and it's put a little dotted line, little highlight around all 3 nodes. I hit delete, all 3 go in the same fell swoop. Okay, so let's just trigger that. Like with templates, etc., it will prompt me to leave a little description of any changes that I've made. I'm not going to go in depth here because I'm going to delete this afterwards anyway, but it is always a good idea to give a little bit of an idea as to what you've changed there, just in case you need to roll it back later. So let's pick on one of my test patients. So we're going to the record. It's going to trigger the housebound one because we know he's got a housebound code on his record. We know it's triggered automatically by retrieving the record. We want to have a look at our chronic disease one. So I'm going to hit F12. Because I'm going to use that a lot, I'm going to pin it by dragging it to one of my letters on my speed dial. Double click. And it's found him on the diabetes and depression registers, so it's not seen a COPD one. So it's given us the appropriate output. Because it didn't find all 3, and we only put the ICE prompt and the appointments prompt if they've got all 3, it's not going to take me into ICE or the appointments. Hopefully that's giving you an idea. As I say, I'm not going to go into, building a whole chronic disease navigation protocol this afternoon because we will be here till the middle of next week. Hopefully that's given a couple of ideas. Let's have, oh yeah, I've developed, yes, I know you developed quite a complex signposting protocol because we looked at it and it was. The question box is really big, doesn't fit on the screen. Can you adjust the size, make this narrower and longer? It's a little bit automatic basically, but you're right. If we put a new node on, so let's put a question. We'll do a new protocol. We're not going to build the whole thing, but so if I put a new question, basically, it's going to, I'm going to have to put loads on here. It's going to stack them in landscape. So realistically, yes, you would have to, you'd have to break your question down and have sort of several tiered questions. So you might say, is the patient presenting, I don't know, with respiratory symptoms or pain symptoms or, abdominal symptoms, etc., etc., etc. I'm breaking down that way. It is one of the pitfalls, shall we say, of it, is that you don't get much by way of formatting apart from the text box. You can't sort of say, okay, open my questions as kind of a list rather than as a across the screen. He says, I'm just trying to think if there's any other clever way I can think of doing that. That's just formatting the question. One thing you can do. Okay, the only way I can think of doing it, it'd be quite difficult actually. It'd probably be more complex than breaking the question down. You could break the protocol up into several smaller protocols. Have the initial protocol trigger a clinical template that has a list of all of the smaller protocols as quick action buttons. You can launch them that way. So to launch a template from within a protocol, like most things, we do it as an action. And we just search for the name of the template. But that would probably be clunkier and give you less scope for going back a couple of steps than if you broke the question down into a couple of smaller ones. It is difficult. It's, you know, that question, basically, that question node will let you expand almost indefinitely, but it will go across. Yeah. Trying to think if there's a clever way of doing it. I don't think there is. It'll basically, you'll expand it indefinitely, but it will just go in landscape format almost till the end of time. No worries. That actually seems like quite a good point to open the floor to everybody. So obviously, really high level overview, just some of the concepts. So we've had a look around the layout of the protocol screen. We've had a look at how we create, amend, publish and delete. As I say, careful with deleting. If I want to get rid of a protocol, but I'm not completely certain I ever want to use it again, what I tend to do is right click and amend. I'll change the category from the details page. So I'll tend to create, like I say, a little Z archive folder. I always put the Z there just because it puts it at the bottom of the list. So all I've done is change the category, sticks it in this little folder down here out of the way. I can then come in and untick the active box. And now if I go into a patient record, when it lets me, bring up my launcher, you'll see that my 2E8 form is no longer active. I can't double click on it because I've unticked that box. We've had a look at the branches and outputs. So we've gone in to do some design work. We've had a look down these. Hopefully I've explained them fairly well, but if anyone wants me to clarify any of them, if anyone's got an example that they're trying to sort of pick out where they might find it or how they might get to it, by all means chuck it in the chat. We can have a look in a bit of detail while we're here. So branches, decisions, effectively, either manual, like a question by the user, or automatic on the part of the system, like checking the patient's age or gender or whether they've got a code on their record. We've had a look at our outputs, so either adding information to the record, add a code, add a note, add a patient plan, showing the user a piece of information, so a pop-up box with some text in it, launching another protocol if we want to get a bit more complicated, or picking an action from SystmOne, effectively anything in the system, launch template, open the appointments book, go into ICE, open an ERS referral. We did mention action return performed, same kind of principle, more restrictive because obviously SystmOne has to be able to test that the thing was done and completed. But things like templates, action return performed basically lets us get the system to check for us whether the user did the thing or not, rather than popping another question up to say, did you fill that in? Remember, it's quite restrictive. And we mentioned the stop node and the fact that actually if there's nothing further, we don't have to put one of those on. If there's no subsequent action, we don't have to put stop at the end of every branch, but it can sometimes make it a little bit clearer, a little bit easier to navigate when you're trying to edit a protocol. We then talked about the options for triggering. So manual, the user has to have the button somewhere, whether they have it on their launcher, whether they have it on the toolbar, whether they go to the protocols node on the clinical tree and search in there, they have to have a button somewhere that allows them to launch this protocol. It's a manual decision. Or we can trigger a protocol automatically. To do that, we have to pick an action that's taken on a patient record. For example, retrieving it, starting a consultation, saving the record, prescribing a particular medication, prescribing any medication, booking an appointment, I think is one of them. Yeah, booking an appointment, recording a death, deducting a patient, etc. if SystmOne sees somebody do that trigger, it will check whether or not we've applied one of these restrictions. So we can say that a protocol, if triggered, will only trigger for specific people or specific types of people. We don't want our GPs prompting to check the patient's phone number particularly, or see if they want to receive text messages, in the same way that we don't want people issuing repeat templates with plenty of time left to make decisions about the patient's other medication. So we can be quite restrictive with who sees which protocols. Also helps keep people on side. Something I haven't mentioned before, I'm going to mention it now. I want everyone to take this away as part of it. There is such a thing as pop-up fatigue. It's very, very real. Protocols are wonderful things, but if you use them for every action that somebody might take in the working day, they fairly quickly get used to clicking OK to get on with things, and your protocols start to lose effect. So be fairly judicious with your restricting triggering to people that need to see that protocol, and be fairly judicious with your filters as well. So that even if it's something fairly broad, like triggered when a patient record was retrieved, we use our filters to make sure it's only triggered. SystmOne only tests the protocol on patients that it should be tested on. And so if we're doing a protocol to prompt non-responders to invitation for mammogram, we don't want that triggering on every patient record. We only want it triggering on patients that will be eligible in the first place. So we can restrict either on age or gender. We can restrict on a report, so a clinical report like we do with the housebound looking for a code. We can restrict it on cloth registers, so we can say it only triggers for diabetic patients. Or as I say, we can restrict it to a group. So we can say this protocol only triggers if the patient is in a particular ad hoc patient list. And you can see some of the examples we've got there. And finally, then we come to our design, and that's where we put the thing together. Okay. Deep breath. So at that point, like I say, floor's very open to any questions. This is the shortened version of the protocol session because it's a Thursday afternoon. We do have a far more in-depth one where we go into some detail with some of the longer examples, for example, the branches based off numerics and that kind of thing. And we can also go through any ideas that you've got, one-to-one if you need us to help play through with you. If you want to look at building one, or if you want to look at some of the more advanced features like variables and subroutines, give us a call through the help desk and one of us will be able to set a session up with you. But at that point, over to you guys. Is there anything you want to have a look at? Anything that you want me to explain in a bit more detail while I'm here? Yeah, send me an email about that one, Marie, because we've touched on it before a couple of times. We'll look at something with that one. That'll take a bit of time. I'm going to put myself on mute for a second, but I'll leave the floor. I'm going to stay around for a few minutes. So any questions, any sort of sparks of inspiration or anything like that, either stick them in the chat or by all means unmute yourself. Just remember you're still being recorded. So, BBC English and all that. But by all means, shout up if there are any questions or anything you want to have a look at. To have a look in a bit more detail if you want, if you've got particular ideas that you want to play through as a practice, or you want to explore whether or not it can be done, stick a call through the help desk. One of us will set up a session where we go into it in a bit of depth. Thanks, guys. Hopefully it's been useful.